We're continuing our conference committee on S.126. I think we left off at section 9. And Jen will put the language up.
Great. And Jen Kirby from the Office of Legislative Counsel. All right, we are up to section 9, which is adding the Healthcare Delivery Advisory Committee, and both versions add a committee. The purposes have changed only slightly. So on the first one, one of the purposes is to establish, and the Senate version said affordability benchmarks, including for affordability of commercial health insurance. There was some suggestion when the bill got to the House that maybe there had already been a commercial health insurance affordability standard developed. So this would more broadly say establish healthcare affordability benchmarks without specifying whether there was or wasn't one already for commercial insurance.
Or you said that there already was
I
one.
think it was something that Blue Cross sent out that somebody had developed last year. I'm not sure if there's necessarily consensus that it is the right benchmark, but I think it confused the issue about whether it was appropriate to call out commercial insurance affordability. So then both have evaluate and monitor the performance of the system. And then in number 3, it's really just, these are some cleanup changes reflecting the fact that it's the Agency of Human Services that is leading development of the statewide healthcare delivery strategic plan. And then the membership is really what has changed. So in the Senate version, there were 14 members. House added some more. One of them is a member of the Health Equity Advisory Commission, selected by the commission's chair. There's so there had been a representative of independent physician practices selected jointly by the Medical Society and Health First. There was a request to separate those. So this would now have in H, one representative of physicians selected by the Vermont Medical Society and one representative of independent physician practices selected by Health First. One representative of advanced practice registered nurses selected by the Vermont Nurse Practitioners Association. One representative of small businesses selected by the Chamber of Commerce, and the executive director of VPQHC or designate. That is, and the other difference from the Senate version did not specifically address per diem compensation or reimbursement of expenses, which likely means members would have been entitled to it. This specifies that they shall not receive per diem compensation or reimbursement of expenses. Discussion.
A couple questions. There's no reference in here to, you've got a independent primary and another primary. Was there any thought about adding a blueprint and ensuring that someone representing blueprint is there?
Stay tuned for the next list.
Okay.
And we separated the two because if we allowed VMS and Health First to choose one, then we wouldn't necessarily have an independent versus.
No, I understand that part. That's clear.
So I think we're going to get to your question next.
Okay, I know we're gonna get.
Yes.
Did you have a question?
Yeah, very small. I'm not entirely familiar with the Health Equity Advisory Commission or the Vermont Program for Quality in Healthcare, but it sounds like they're trying to. It's very patient focused, high quality healthcare, and advocating for patients. That's what it sounds like.
We set up the Office of Health Equity. What was that in 20?
Department of Health. It just got moved to the Department of Health.
Yes.
And it looks at differences between groups. So if you see that
Disparities.
Disparities.
disparities, health disparities,
And so we figured since
we can talk about
we're
it. And then we'll share them.
Oh, that's all it was.
Okay.
And just going off the names of them, I don't know, Mike Fisher does a good job advocating for a lot of those things. I just didn't know if adding more people is necessary if Mike already kind of does that. So,
We'll talk about
but yeah.
Okay.
You had a second question, I think.
Well, we're getting there.
Okay.
So, the second question was on the addition of the small businesses,
Yes,
selected by the Vermont Chamber of Commerce. And that is,
it was felt that if we are developing a statewide healthcare delivery strategic plan, that perhaps we should have a representative of small businesses who are actually trying to deal with the affordability of offering health insurance to their employees. And there were no other representation other than health insurers themselves. There was no one really advocating on behalf of the business consumer who
Okay.
is having to purchase.
there wasn't any consideration of sort of reaching out to folks. You've got having a core group of membership and then reaching out to other interested parties, including business or others.
Well, we had put in the beginning that they could reach out to anybody else that they felt was necessary,
Yep.
but we felt it was important enough that their voice be heard on this, that we didn't want to leave it to AHS to say, hey, I think we'd like to hear also from small businesses.
Okay. And so,
And I will say that this language was added because one of our members is a small business owner, actually, to myself, who is actually not able to afford insurance for
Got
her
it.
place.
okay. And the interest in access as well as affordability. Okay, all right, that's helpful. Okay,
Okay, so now we're at section 9A, which is the new section on creating a comprehensive primary healthcare steering committee. So it's not all highlighted, but it is all new. So this has a steering committee created to inform the work of state government, including the Blueprint and the Office of Healthcare Reform and AHS, as it relates to access to, delivery of, and payment for primary care services in Vermont. And then it has a number of members. Down at the bottom to get the 16, it has 16 members. I don't know if you want to go through who they are.
I think we're good. I mean, we read through the membership. I'm going to ask some questions about it.
And the steering committee is directed to engage in an ongoing assessment of comprehensive primary care needs in Vermont, provide workforce recommendations, develop proposals for sustainable payment models, primary care, identify methods for enhancing access to primary care, recommend opportunities to reduce administrative burdens on providers, recommend mechanisms for measuring quality of primary care, provide input into the plan as it is developed, updated, and implemented, consult with the Green Mountain Care Board if the board develops reference-based pricing for primary care providers, and offer additional recommendations and guidance to the Blueprint, the Office of Healthcare Reform, General Assembly, and others in state government on ways to increase access and improve patient and provider satisfaction with primary care.
Okay. So I'm interested in, understanding that the group that we put together, the advisory committee that we put together was really based on the rural healthcare folks and what the work that they had done. And there was some focus on primary care there. There's also the Green Mountain Care Board Advisory Committee. There's also the Blueprint Executive Committee. And then the Vermont Medical Society is very keen on primary care and has a whole list of recommendations already in place. Now, let me keep going here for a second. So this is a whole new group. And my understanding, and you can correct me if I'm wrong, my understanding is that there are all of those groups out there, but none of their recommendations are ever taken into consideration. What makes it different here? So my question, I will be bringing a recommendation on this, just to let you know. You've got all these groups, you've got several different sets of recommendations, and we very much want them to fold into the work that's being done with the plan, whether it's strategic or not. And so so we'll be thinking about this. The other question, I know that you've got the Lerner College of Medicine in there and the work that they do through the dean's office or situated in the dean's office is AHEC. I don't know if you considered AHEC at all in this process, whether, because I'm thinking, whoa, they're across the state, they represent different parts of the state. They have information that would lend itself to the plan. So I just took off from primary care and going back and forth here. So having a whole nother group is interesting. I think our committee is very much supportive of improving access and, having cost-effective access to primary care. We would like to see that, just thinking about how best to do that within this context.
So my first question is, are you advocating that we get rid of this or that we add a 17th member to it?
Well, I will bring you back a suggestion on this. How's that?
I will tell you, this section is the section that I added. And yes, we do have primary care advisory group within Green Mountain Care Board. There is also I'm not sure what they're referred to that's in the blueprint.
They have an executive committee. They work together.
I'll be honest with you, they have a committee that I've never actually even heard of or heard from before. And
we just got a report from John Soroya.
well, we got that from the blueprint though.
Yeah.
But I think my feeling was, and this has been my feeling all along, and if we're doing a strategic plan, we know that more than 50% of the care that is delivered in the state of Vermont is in primary care. And it seems to me that if half of the healthcare that's delivered in the state is primary care, perhaps primary care should have a significant seat at the table rather than being relegated to just another advisory. Okay. And when you set up things like the steering committee that has to include everyone, what ends up happening is primary care gets one seat. And what I really wanted to do was to set this up, and I will be honest with you, my goal is to have this as the committee. And eventually we will be able to then repeal and replace PCAG as well as Blueprint Advisory. That this strong committee on comprehensive primary care, which is why I've included representatives from social workers, psychologists, because when I think of primary care, I think of a comprehensive primary care
community health team.
A community health team.
Exactly.
I think of what the blueprint is. It's a blueprint for comprehensive primary care, not funding, but what that is. And what they do is they will advise, they are working in consultation, just like the steering committee with AHS in the development of this. So I want them to have a bigger seat at the table.
Got it. I think there's a lot of agreement with that. It's just how it happens. And
Okay.
so, yes. So when we put the blueprint together, there was a strong interest in having it be a model for all primary care across the state. It's become a separate program with its own set of evaluation. That's a whole nother discussion. Anyway, good. Thank you.
Okay. So are we done with that section
Yeah,
for the moment?
for now.
And we get into data integration and data sharing. So these sections are pretty different between the Senate and the House. The Senate version adds a new statutory section on integration of healthcare data, requires AHS to collaborate with the Health Information Exchange Steering Committee in the development of an integrated system of clinical and claims data in order to improve patient, provider, and payer access to relevant information and reduce administrative burdens on providers. and it sets out what the agency's process would look like. And would require health insurers to provide clinical and claims data. It would require the agency to provide access to data to state agencies and healthcare providers to the extent data use agreements allow, and require an annual update regarding development and implementation of the system. The House version is instead, it's not codified, it's a session law provision because it's a one-time report. And it would have AHS, again, collaborate with the Health Information Exchange Steering Committee, but in this case, to evaluate the potential for developing an integrated system of clinical and claims data. And it requires the agency's analysis to look at feasibility, potential uses, the extent to which an integrated statewide system would improve access to relevant information, reduce administrative burdens, increase access and quality of healthcare, and reduce costs. To look at appropriate privacy and safety, security safeguards, and any additional considerations, and then provide findings and recommendations by January 15th of 2026. And in addition to the particular items above, it would also require the agency to explain the pros and cons of developing an integrated system, provide recommendations about whether it should be pursued, and describe the value, if any, that the integrated system would bring to Vermont's healthcare system. And then it would specify that AHS shall not begin implementation of an integrated statewide system of clinical and claims data unless and until directed to do so by legislation enacted by the General Assembly.
Okay, well, there's significant differences between the two. And one, I think for us, we're interested in having a clinical database that's accessible across the state.
Yep.
So that we can have data integration, interface, much as interoperability as much as possible. And then also sorting out how the data is used for research as compared with clinical work. The integration of clinical and claims data is what you have focused on, I think, here. And we've seen that as just a piece of everything else. So maybe there's a way we can sort that out.
I think that there probably is.
Yeah.
And I will say, we share those goals.
Yes, okay, good.
We absolutely share those goals. I think we just felt as though what came over to us was really more about a continuation of work that AHS has been doing within their own systems to merge clinical and claims data and around sort of quality or reporting. But what we heard testimony over and over and over again from providers was, we just need to know where our patients have been, what tests they've had, what the result was. And we need that in real time, and we need that on a single sign-on within our own systems where they can have that information included, pushed into their existing medical records. And we didn't feel as though the claims and clinical data merged together in some other, we thought that would take precedence over what we really think we need, which is work that Vital is already doing in interoperability. And they have the ability at this point to be able to merge the clinical information in Vital into systems. They just need the resources and the, what word would I use? Encouragement to deploy it in a faster manner than currently is happening.
Get different organizations, institutions, and providers to have access to.
Yes.
Yeah, so, yeah, I think that,
Make it cost effective.
Right,
For providers to have access.
and so we'll look through what we have and we'll look through what you have and we'll try to sort out, maybe we can do that together.
Sure.
Sort out how we can move on.
I will say, I think that after it left the Senate, there was AHS, Green Mountain Care Board, and the Office of the Healthcare Advocate had worked together on some compromise language that we really didn't frankly look at, that I think by the time it came to us, we had already decided that we were gonna go back to a report back.
Okay.
But we should look at maybe that language
Okay.
again and
Yeah,
see
let's
if that
sort
meets.
that out. It would be
meets all the
good.
needs.
Thank you. All right, yeah, great.
Okay, section 11. Section 11 is the section dealing with the Green Mountain Care Board's authority to share materials it receives pursuant to a subpoena or notice to produce with another state agency. So the language that came from and that was in the Senate version was with another state agency as appropriate to the work of that agency. The House version is narrower. It allows sharing with the Agency of Human Services or Department of Financial Regulation or both as appropriate to their work.
Okay. Want to share it with the Agency of Transportation? Okay, well,
Do you wanna give it?
No, that sounds good. That sounds good. Well, I think we're fine with that.
All right, now we get into several new sections. These are sections 11A through D. And section 11A is directing the Agency of Human Services to facilitate collaboration and coordination among healthcare providers to encourage them to work together to respond to the urgent financial pressures facing the healthcare system, identify opportunities to increase efficiency, improve quality, reduce spending on prescription drugs, and increase access to essential services while reducing hospital spending for hospital fiscal year 2026 by not less than 2.5%. Requires AHS to facilitate and supervise participation as necessary to protect against antitrust concerns. It requires the agency to report on the proposed reductions that it approves, including applicable timing and appropriate accountability measures to the Health Reform Oversight Committee, HROC, and the Joint Fiscal Committee on or before July 1st, 2025, and then would have monthly reporting on or before the first day of each month of hospital fiscal year 2026, so beginning on October 1st. So updates, monthly updates to HROC and Joint Fiscal Committee when the legislature is not in session, and to your two committees when it is, regarding progress in implementing and achieving the hospital spending reduction.
And I would say this section and 11A, B, this came out of our joint hearing that we had recently with hospitals and Green Mountain Care Board. A sense of urgency and the
Are you talking about the Act 167 update?
yeah, yes, sort of, this is accountability for Act 167 and Act 51. So that's
And then
directly where this
section, yeah.
this section.
How does this relate
Directly
to
out of this.
reporting that's in Act 167?
There is no, there isn't.
Right, I think the Act 167 reporting is complete
Okay, now,
as far as what was required.
okay. All right, we'll have to think about this. It seems like a lot. As I go through and I look at the next sections where you're having reports back, it's a report after report after report.
I know it has the word report.
Does.
It
But
does.
what we're really
right,
doing
It's really
is
an
we're,
update. It
it's
says
updates. We're
So, I mean,
asking
there's
for
report and an
updates
update.
on the work that they're doing. And we're asking for frequent updates on the work they're doing in implementing
Okay.
Act 167.
And then on the reducing hospital spending for hospital fiscal year 26 by not less than 2.5%. How does the Agency of Human Services accomplish that?
By working in collaboration, facilitating and supervising the hospitals as they come together to work on how they're going to reduce. I think the Senate and the House has been working very diligently over the last few months on trying to figure out how we're going to reduce costs to the system. And again, this section came out of that joint hearing with, the concerns of hospitals are saying, oh, we're working towards this. But I'm not sure we saw evidence that they were working together as quickly with the same sense of urgency that I know House Healthcare has been working and Senate Health and Welfare has been working. And that is why we have this in there. And we haven't gotten to the carrots yet.
Okay, we'll get to the carrot. Now,
Okay.
so how does the 2.5% relate with what the Green Mountain Care Board might be doing on setting global budgets or a 2.5% cap growth rate or with reference-based pricing?
This is only for hospital fiscal year 26. So this is the hospital budgets that they will be submitting in August of this year.
Right, these are the budgets that start in
These are
October.
the budgets that start in October.
Okay. And did you hear from hospitals that they are already doing something like this?
They have indicated, and they indicated to all of us in that joint hearing what they have been doing, but I think they also expressed frustration in that, they had ideas, but they weren't able to get buy-in from all the hospitals. And this would allow AHS, because of antitrust and continuing to work on 167 that we've tasked them to do, this would allow them to supervise and facilitate and help the hospitals come together with their creative thinking around cutting some of their budgets.
Okay. We'll look at this.
Did you have a question?
What?
Did the hospitals give any specific testimony on these specific sections in your committee? Because you mentioned they gave testimony in the big joint hearing, which I remember that, but did they testify specifically in the committee on these?
They did testify. We had just the process that we took with this bill was we took section by section by section, stopped, took all of the testimony on that one particular section, then moved on to the next section. So we had multiple people back in multiple times. And I have to be honest with you, I am blanking on what Vaz testified to on
It's okay.
11.
Yeah. We're yeah, no, we got it.
Frankly, I'm not sure they had any concerns.
Well, I'm not sure they came in with specific testimony. I think they were, consulted and some modifications were made based on their feedback from the side.
Thank you.
It's good not to the language. And I think there were some conversations that happened outside the room that informed what came back into the room.
Yeah.
Yeah, there was a lot of that.
Yeah.
They were in the room and sometimes they'd be up there and sometimes they'd be over here.
Yeah, got it.
Yeah.
That's the fun part.
All right. So section A is really the very short, I would say the very short term kind of spending reduction. Section 11B is looking at some of the evaluation of and accountability provisions for Act 167 transformation. So section 11B requires the Agency of Human Services to identify specific outcome measures for determining whether, when, and to what extent each of these 5 goals of its healthcare transformation efforts pursuant to Act 167 have been met. And these 5 did appear in Act 167, and I think they were also, and part of the reason they ended up in here was they were highlighted in a slide in that joint hearing that you all had with AHS and the hospitals on 167. So as goals. So they are reduce inefficiencies, lower costs, improve health outcomes, reduce health inequities, and increase access to essential services. And then this has AHS reporting to HROC and the Joint Fiscal Committee on or before July 1st, 2025. On the specific outcome measures it developed, along with a timeline for accomplishing them. How the agency will determine its progress in accomplishing the outcome measures and achieving the transformation goals, including how it will measure savings and evaluate increased access. The impact that each transformation decision that a hospital makes has or will have on the state's healthcare system, including costs and premiums. How the agency is tracking and coordinating the efforts of individual hospitals to make sure that they make sense across the system. And the amount of state funds and federal funds, if applicable, that the agency has spent on Act 167 transformation efforts to date or has obligated, and the amount of funding that remains. And then there would be some updates on or before the first day of each month, beginning August 1st, to HROC and Joint Fiscal Committee out of session, and your committees when the legislature is in session. And I'll just flag that all of these have reports in the title, partly just for our tracks, how we flag things so that we can help you track what you are expecting, whether that's in the way of a specific report or updates, whatever other terms we use.
So one of the things that we have in our plan process is to have the 167 process integrate in with the plan. So that's why the period of time for looking at what are all the transformation things that are happening to identify a lot of the things that you have here. Maybe we can add those into the plan process rather than having a separate report on 167, but to begin to merge the Act 167 process with the planning process, so because they are so very much related and integrated. So we'll think about that.
I think
about this.
about the timing of things.
Right. Well,
I
it
consider
starts
this an
out,
extension.
I'm kind of concerned about, well, we want to really move forward with the planning place, find the gaps, find the barriers. We want to fill in those gaps and barriers. We don't want to hold ourselves back we don't want to hold anyone back from getting the work done. The work will have to be done if we set specific targets, timelines. So it would become an ongoing process. 167 was the first lift, then the next lift is moving it into the plan and the planning process, looking at what hospitals are done. I know we heard from very few hospitals, or a lot of work, there is some work going on. How much AHS is doing is, we need to ask that question, but let's see how many report updates. This is an update about.
It's an update.
It's a lot. It's a lot of work here for the agency when they are already looking at other work. So that's my perspective anyway.
Okay, again, it's an update. I consider it to be the equivalent of when they came in to our joint committee and said, here's what we did in January. Well, here's what we did.
Well, and in January, they had just hired their contractor. So now we need to hear back on what has happened with the contractor.
That's what.
Is that, and how does that merge into the planning process? That, I'm thinking. Okay.
Okay.
All right, section 11C directs the Agency of Human Services to award grants to hospitals in state fiscal year 2026 that actively participate in healthcare transformation efforts to assist them in building partnerships, reducing hospital costs for fiscal year 2026, and expanding Vermonters' access to healthcare services, including those delivered using telehealth. And it expresses legislative intent that the funds that are now in section 18, 18B, which is a total of $2 million, should be awarded on a first come, first served basis until all of the funds have been distributed. So this is really, as the language says at the beginning, encouraging hospitals to engage proactively, think expansively, and propose transformation initiatives. And it would have AHS report by November 15th to HROC and the Joint Fiscal Committee about how much of the $2 million was obligated as of the first of that month and how much had already been dispersed to hospitals as of that date.
And what did we use the $2 million for?
This,
Okay, came from the HIT.
right, this comes from the HIT fund.
Oh, this is the HIT.
Right, but it's for the work in 11,
Got it. I remember. Sorry.
11A and 11B. Section 11D is directing Department of Financial Regulation to report or to provide a plan to HROC by November 1st of this year, a plan for preserving the sustainability of domestic health insurers in Vermont, which may include using reinsurance.
Sounds good.
So it's just enough.
Let's give somebody else work.
Well,
Good, I like it.
Well, no, I mean,
Yeah, no,
we
you're
have
right.
been receiving updates from the
Yeah.
Department of Financial Regulation, and we
Yeah.
know that they are monitoring the solvency.
Right,
Got it. This is just an update.
yeah. Okay,
Right, and a plan.
And yeah.
I'm good with that.
All right, section 12 is retaining ACO capabilities. The only change that is here is just that I needed to clean up the heading, section heading, because we, in the Senate, originally had Agreement and Care Board and the Blueprint for Health doing this. It changed to the Agency of Human Services still in the Senate, but I neglected to update the section heading, so that's really clean up.
Can we close this section?
Yeah, so, okay, so you gave it to AHS.
You gave it to AHS.
We gave it to AHS.
I
Yes,
just
we
didn't,
did.
I just didn't reflect that
Got it.
change in
And
the section heading, so that's all that's
we're
happening.
fine with that.
Close.
Everybody's good. Section 13, this was where the Senate had an implementation report by November 15th from the Agency of Human Services about its implementation of this act, putting an update on its work on the statewide healthcare delivery strategic or non-strategic plan, advancing healthcare data integration, and exploring opportunities to retain ACO capabilities, as well as its Act 167 activities and the effects of these efforts and activities on Vermonters and on Vermont's healthcare system. And the House moved many of these things into other reports or changed timelines or did away with the underlying duty.
We could just take all those reports you had earlier and just, they're here.
Well, I was gonna say that's one of the reasons this moved was because we were generous and put it into another report. So
You got rid of this.
we didn't make daily reports.
Okay,
Section 14 is Agreement and Care Board Implementation Report that is due by February 15th of 2026. That was the case in both Senate and House versions. Requires an update on the board's implementation of this act, including in the status of its efforts on reference-based pricing. And then the House version strikes development of global hospital budgets. Here's where it comes in this section. And changed the language throughout around the effects of these efforts and activities on Vermonters and on Vermont's healthcare system, to the effects of these efforts and activities on increasing access to care, improving the quality of care, and reducing the cost of care in Vermont. And then here's where the board would also report on the potential future use of global hospital budgets, including providing the board's definition of the term global hospital budgets, determining whether it is feasible to develop and implement them for Vermont hospitals, and if so, over what time period, and the pros and cons of pursuing global hospital budget.
well, there's a big difference there.
There's a big difference.
Got it.
You put in what is the definition of a global hospital budget though?
Yes, definitely different takes on what that is. Section 15 is the ongoing AHS annual report that was added in the Senate, but a bit restructured here and in the House version, and removing references to advancing healthcare data integration and coordinating hospital transformation activities. Also requires the agency in the House version to adopt an evaluation framework using an evidence-based approach to assess both the effectiveness of plan development and implementation and the plan's overall impact, would identify what was accomplished, how well it was executed, the benefit to specific cohorts within Vermont's healthcare system, and would require the agency to include updated evaluation results annually as part of its report. Would also have them report on the activities of the Healthcare Delivery Advisory Committee and the effects of the strategic plan, the efforts and activities of the advisory committee, and other efforts and activities engaged in or directed by the agency on increasing access, improving quality, and reducing cost.
So the activities of the Healthcare Delivery Advisory Committee, actually, all we need to know is how is the plan moving forward and where do we need to direct our resources? So,
So you've given the advisory committee a number of sort of discrete, non-plan related duties because they're supposed to be monitoring ongoing delivery. So you may want them to report, somebody to report, when we do not have the advisory committee providing an annual report.
I feel like they're spending all their time reporting and not doing. Anyway.
And I will just note that it is 11:59. I don't know, you have a noon, and so
I do have a meeting. So I think it would be helpful for our committee to get together and to talk about where we are with some of these things. We're not that far from the end.
Would you have time to do that before 1:30? And we
I was thinking if we could try and do that at 1:00 or,
No, if your committee, and then we can reconvene together at
yeah, so we'll do that at
12:30.
Might have finance. I'm not sure.
12:30. Can we do it at 12:30?
Yeah.
Can you do it at 12:30?
I guess I'll go get lunch.
Okay,
Okay,
grab lunch.
can we reconvene here at 12, or at 1:30? We have to be back on the floor at 3.
Yeah, let's do that. We're on the floor
So
too.
we're meeting at 12:30 and we're meeting here at 1:30.
1:30.
Okay, it depends what I've got in finance, but I'll try to get out.
I don't have, I have something at 1 and approach, but you know what, we may be able to meet at 1:15, so I'll text you again.
Yeah. Update, yeah, we could, is it you two okay with 1:15 if we need to meet a little earlier?
Yep.
Okay.
Okay.